Good morning, everyone. We're going to get started. My name is Olya Koloris. I'm the pediatric nephrologist here at Stanford. Welcome to Grand Rounds on behalf of our Department of Pediatrics, our chair, Dr. Leonard, who couldn't be here today, and our Pediatric Grand Rounds Committee. To acknowledge Stanford sits on the ancestral land of the Muekma tribe, and we want to acknowledge that each Friday. I also want to remind you that you can register for Grand Rounds in your presence and get credit using the text code to the left. And then go to CME Cloud and claim your CME credit as well, or give us any feedback. Reminder, today's session, we have Dr. Duggan visiting from Boston Children's and Harvard Medical School, and we'll let our section GI chief, Dr. Hussein, do formal introductions in a moment. But just as a reminder, upcoming Grand Rounds are coming on March 10th. We have a special speaker coming from Puerto Rico, pediatric nephrologist, Dr. Melvin Bonilla-Felix, who will talk about global pediatric nephrology, serving the vulnerable in the crisis. And then on March 17th, we have our Crowley Down lectureship in pediatrics, speaking on a peek into the future of medical knowledge. And our speaker is Todd Ponsky. Just a couple other reminders there about the upcoming MCHRI seminar. The next topic will be on March 8th, and it will be both in person and virtual. And this will be on deciphering the Warburg effect, metabolic reprogramming, epigenetic dysregulation, and cell differentiation, presented by Drs. Ye and Jiang. Another reminder on the pediatric update. This is a call for proposals for ideas for this event, which will be on June 9th to 10th this summer at the Arrilaga Alumni Center. So feel free to send your proposals for this meeting. Another reminder, which we already mentioned previously, is about calling for mentors for a pediatric internship program at Stanford, which serves to excite high school students in the area in the medicine, science, and research at Stanford. And so feel free to use the contact information here to volunteer as mentors. And back to today's lecture, Dr. Duggan will be speaking about the intestinal failure. And in this session, we'll review the definitions, epidemiology, and natural history of intestinal failure, with an emphasis on neuronutritional and medical therapies. And Dr. Hussein will, our section chief for gastroenterology, hepatology, and nutrition, will give formal introduction. And before that, just to remind you, at the end, we will put up a slide on instructions on how to raise your hand for questions so that everybody knows, both on Zoom and in this room, who you are and what the question is. Just a reminder, we do have a large audience online. We want to have everybody get access to what the questions are and who are the people asking questions. Thanks so much.
My name is Sohail Hussein. I serve as chief of the GI division. It's my pleasure to introduce Dr. Chris Duggan, who's the Meltzer Professor of Pediatrics in the field of Gastroenterology at Harvard Medical School, and a Professor of Nutrition and Global Health Population at the Harvard Chan School of Public Health. He has a long series of accolades. I'm going to tell briefly about them and about him, so it frames the weight of his talk today. He completed a bachelor's in philosophy at Dartmouth, and we may hear some philosophy today. Dr. Duggan went on to medical school and pediatric residency at Johns Hopkins with Frank Oskey, as I heard this morning. And it was here that he solidified an interest in nutrition with gurus in the field such as Al Summers. He went on to do a pediatric GI fellowship at Boston Children's and a master's of public health, and there he stayed since. He is the director of the Center for Nutrition. And if I had to summarize Dr. Duggan's work, he acts both locally and globally. As director of the Center for Nutrition at Boston Children's, his clinical interests are in the nutritional management of a variety of patients, who, including those who have cystic fibrosis, cancer, HIV, and intestinal failure, which he'll tell us about today. He's the director of enrichment for the NIH-supported Nutrition Obesity Research Center, and his global health interests are also vast. And they are in the nutritional management with active clinical trials in acute persistent diarrhea and specifically micronutrients in resource-poor regions of the world. Dr. Duggan serves as the editor-in-chief of the American Journal of Clinical Nutrition and various other editorial boards, and as Paul Fisher reminded me, also the Journal of Pediatrics. Dr. Duggan has many accolades, including over 350 publications, editing several textbooks, including the Manual of Pediatric Nutrition, past and present support from the NIH, the Gates Foundation, the WHO, and the recipient of several prestigious awards, including the Wiesner-Wenzier Award for Excellence in Medical and Dental Education from the American Society for Nutrition. You've heard the title of his talk. He'll tell us about intestinal failure, the past, the present, and importantly, the future. So please join me in welcoming this outstanding international nutrition expert and bedrock in the field of pediatrics and gastroenterology, Dr. Duggan. Duggan.
Thank you so much, Sahar. Thanks so much for that really generous and over-the-top welcome. I will say it's really a pleasure to be back here at Stanford. I was here a few times in the 1990s and in a network called the Glaser Pediatric Research Network, so I was able to meet some old friends then, and it's been great to come back and see how not only the buildings have changed, but the people have really expanded greatly. So Hill didn't mention that I had a series of talks with his division members and others in the department and the hospital, and it's just really fantastic to see what he and others have built here. So congratulations for that, and thank you for welcoming me. And it is true that the epistemology of my lecture, if you want to talk philosophy, we can talk about how we know the things that we know. Indeed, people might say, well, why did you pick 24 years as the reflection point? It turns out that in 1999, we at Boston Children's Hospital started the Center for Advanced Intestinal Rehabilitation, our rehabilitation program. And it was on its anniversary a few years ago that led several of us to think back in time and see where the field has come. But as Sohail mentioned, it's nice to see where it might be going as well. I do have a handful of conflicts of interest that I need to disclose. Number one, the company Takeda supports a multi-center, multi-state study we're doing to evaluate the natural history of the medication teduglutide. I'll be speaking about teduglutide in today's lecture. I'm an author for Up to Date and the editor for AJCN. So I was asked to put together 3 learning objectives. We'll review the definitions of intestinal failure, both in children and in adults. And getting back to epistemology, you really can't know something unless you define it, hopefully quantitatively. We'll talk about trends in epidemiology of pediatric intestinal failure. I was anxious to make sure that this wasn't just a GI-specific talk, and I think those of us in the broader child health world all struggled with this issue of formula shortages. I'll talk about that to a certain extent, and then we'll talk about treatments, new treatments for children with pediatric intestinal failure. Well, what about different definitions of intestinal failure? I think a picture says 1,000 words, and I'm sure I showed these slides when I was here a few years ago, but reminding us all that the etiologies of surgical short bowel syndrome are quite varied and include things like intestinal atresias in the top left, gastroschisis, neck-present enterocolitis, and Hirschsprung's disease in the lower right. And so that's an important concept, that various etiologies can lead to the final common pathway of short bowel syndrome. And in a figure that the New England Journal artists nicely put together for a review article, this really points out 2 things. Number one, when a child comes to your office, maybe it's the neurology office, maybe it's the renal office, these infants on the outside kind of all look the same. They're often young. They often have a central venous catheter in place with a gastrostomy tube. But they're very unique, and their uniqueness is driven by their anatomy often, and their anatomy and their physiology are going to drive both approaches to medical and surgical therapy. The other thing that this figure points out quite nicely, I think, is that even though we think of short bowel syndrome as a disease primarily of reduced surface area of the small intestine, it really is a multi-organ system condition with implications for the health of the heart and vasculature because of chronic vascular mechanical devices that can lead to thromboembolism. Obviously, the intestinal failure-associated liver disease is an important morbidity. There is reasonable data to suggest that pancreatic exocrine insufficiency can accompany short bowel syndrome. And more specifically, in addition to the specific loss of small and large intestine, which certainly drives the medical and nutritional therapies, it's essentially an anatomy lesson for everyone, for every student that I see these patients within clinic, in terms of saying, well, if they've lost that amount of bowel, they're more likely to be at risk of this nutrient deficiency. There are also systemic effects, including increased mucosal permeability, the so-called leaky gut phenomenon, as well as issues with oral aversion, neural development, et cetera. So it's truly a multi-system disease. Well, in terms of definitions, the conceptual definition is as follows: a reduction of functional intestinal mass necessary for adequate digestion and absorption for nutrient, fluid, and growth requirements. And that's a nice concept, but I would argue that applying that concept is a little bit murky when you design clinical trials or clinical studies. Three major classifications of intestinal failure, of course, are short bowel syndrome, motility disorders, and I would argue that many patients with short bowel syndrome, especially those with, say, gastroschisis, have both reduction in surface area as well as dysmotility, and then the rare but more severe events, including intestinal mucosal defects, epithelial defects, including secretory diarrhea of a variety of causes. Now, I mentioned that the term intestinal failure has kind of gained credence in the literature, and this slide kind of shows that it wasn't until the 1980s and 90s that the term kind of caught on in the PubMed literature in analogous fashion to kidney failure, heart failure, et cetera. But a few weeks ago, it was driven home to me. We had the marketing people come to our clinic, and they were all excited about putting up videos on our website to attract more patients, of course. And I started talking about intestinal failure this, intestinal failure that, and they said, cut. People don't like to hear that their organs have failed. Let's talk about rehabilitation. So indeed, we do talk about rehabilitation a lot, but it's true, when your organ fails, it fails. The adult literature is really a mess in terms of definitions of short bowel syndrome, which I've kind of summarized here in this slide. That there's just been every which way of attempting to define this condition, which is really quite surprising. There's even an attempt to break down in adults type 1, which is allegedly self-limited intestinal failure. That sounds odd. I don't even know what a prolonged acute condition means. And then maybe it's a chronic condition over months to years. So I haven't really been impressed with the way in which the adults have defined it. They've even made an attempt to differentiate different types of intravenous supplementation, whether it's the volume or the caloric density of the need. So I'm not sure the adults have really advanced the field tremendously. They do have this important approach of defining the conditions based on anatomic origin and anatomic status of the small intestine, whether a patient has an NJ genostomy and no colon, whether a patient has a jejunum attached to partial colon in the middle, or whether both small intestine and ileum are in continuity of the full colon. And it is true that these anatomic differentiations are helpful in a prognostic and therapeutic way. As I said, I really do think the pediatric world has led this. Judy Sondheimer many years ago used the cut point of 90 days of parenteral nutrition use. And you can argue, well, what's so special about 90? Oftentimes 90 days would be the time where common morbidities of intestinal failure might rear up in terms of intestinal failure associated liver disease or other complications. A group that I was involved with a few years back, which was a multi-state, multi-country analysis called Pediatric Intestinal Failure Consortium, proposed a somewhat more liberal definition, if you will. Basically, we used a cut point of 60 days. I honestly can't remember why we used that cut point from 90 to 60, but it had the obvious implication of broadening the criteria and increasing the sample size of children we could study. And then finally, my colleague in surgery, Biren Modi, and my colleague in pharmacy, Kathy Gura, put together recent definitions, which basically use the 60-day minimum of duration of parenteral nutrition as a defining criteria, but saying that it happened to happen within a 74-day consecutive interval, taking into consideration for children who are off of parenteral nutrition for operations or other kind of acute metabolic problems. So it seems to be a reasonable approach. So in conclusion, the adult definitions, I think, are less clear-cut and rely more on anatomy, but the intestinal failure definitions in children are really driven less by anatomy and more driven by the need for specialized nutrition support. And I think that has an important concept in how we might compare literature in adults versus children. Now, I will say this intestinal failure diagnosis is a really important one, because if you're coding a child who has intestinal failure, the insurance companies might want to say, well, how have you defined that? And I actually wrote a letter to JPEN to say, well, it shouldn't, you can still have intestinal failure and be weaned from specialized nutrition support, because those are the children who actually have the most complicated nutritional problems, because they're not getting parenteral vitamins and minerals and things. So I vote yes, that the definition does not require ongoing dependence on PN, but I do wonder whether insurance companies will see it that way as therapies that we'll talk about later come into the forefront, because it's quite expensive. So stay tuned for that. Questions about the definition of intestinal failure, and I should mention that Sohail is nicely monitoring the Zoom chat in case there are questions, and there will be interactive quizzes coming up. All right, so let's segue into the epidemiology of intestinal failure. And here's the first quiz. This is a mortality quiz as opposed to a morality quiz. I would never want to give one of those. From 1986 to 1998, a long time ago, the all-cause mortality rate at Boston Children's Hospital with short bowel syndrome would be defined as 90 days of PN dependence, regardless of parental nutrition status, namely they could be on parental nutrition or off parental nutrition, was, and we can do a show of hands in person, 90, 50, 30, 10% overall mortality rate, all-cause mortality rate. Anyone say 90%? Anyone say 50%? Couple, anyone say 30%? And anyone say 10%? Okay, good. So nice. Are there any Zoom chats? Is there anyone out there? Is anybody out there? It is 30%. Okay. 30% is a remarkably high figure for all-cause mortality rate in any condition of pediatrics. So that was pretty impressive. And we wrote that up in a case series in 2001. Okay, our next quiz is as follows. What was the all-cause mortality rate in children who had short bowel syndrome, 90 days of parental nutrition, who were unable to be weaned from parental nutrition, who were stuck with parental nutrition, okay? So 90%, 50%, 30%, 90% anybody? 50% anybody? 30% anybody? 10% anybody? Yeah, so good logic there. 90%. It's unbelievable. And, you know, I was looking back on this and I was like, well, that's unbelievable. And indeed, for comparison's sake, the same hypoplastic left heart syndrome in the same time period was about the same. So really, short gut syndrome was our hypoplastic left heart syndrome, a complicated congenital anomaly, oftentimes that had a really high morbidity and mortality rate. All right, final quiz. How's the Zoom questions going? Okay.
You respond to the quiz. Can you just tell the Q&A?
Oh, can they just? Oh, I should have had A, B, C, and D. They just typed the number in the chat. Yes, please. Oh, sorry. Okay, my bad. That's the last quiz, I promise. From 2002 to 2014, a more modern day range, the all-cause mortality rate for children with short bowel syndrome, regardless of parental nutrition status, was, anyone that wants to say 90%, 50%, 30%, 10%. Most people say that. It's a trick question. It's 3%. Sorry. It's terrible. It's terrible. They're never going to invite me back. But it really is dramatic, right? So that, I mean, I'm old, but I'm not that old. And within a moderately short academic career, I've literally seen a total sea change in mortality rate. And I'm sure other people who have been doing this for a while have seen the same thing. It's been a dramatic change and a really exciting one to see and be part of, to be honest. So let's talk a little bit more about epidemiology, maybe some clues about why that happened. The data on the population-based data on the prevalence or incidence of short bowel syndrome is terrible. It's old. It's not really clear what criteria were used. So this is a group. Paul Wales is a pediatric surgeon who, for many years, was in Toronto. He's recently moved to Cincinnati. Using the CAPS definition, the Canadian Association of Pediatric Surgeons, which was a 42-day dependence on parenteral nutrition after bowel resection, or concomitantly a residual bowel length that was 25% expected for gestational age. They found among premature infants an overall estimate of the incidence of short bowel syndrome of about 353 per 10,000 live births, or 3.5 for term infants per 10,000 live births. Very wide confidence intervals, and only in one kind of area, geographic area. In the United States, Conrad Cole, who's still at Cincinnati, collaborated with folks from the NIH and evaluated kind of what the burden of disease was in 4 different types of short bowel syndrome or GI conditions, including medical neck, surgical short bowel syndrome, or no necrotizing enterocolitis. Looked at mortality rates. You can see the percent survival was really terrible over the course of illness, and did estimate that the incidence of so-called surgical short bowel syndrome was about 7 per 1,000 infants in low birth weight and very low birth weight infants of 400 to 1,500 grams. And these are, as far as I know, still the only kind of population-based estimates of this condition. And as I mentioned, because the shifting sands of the intestinal failure definition has gone on for the past few decades, it's really difficult to really put a number on it. But certainly there seem to be a lot of patients who come to seek care. Paul also was a senior author on a very influential Journal of Pediatric Surgery meta-analysis, which basically looked back at all of the case studies and case control studies of this condition. And indeed, anyone who takes care of these kids in the 1980s and 90s published, 30 patients here, 25 patients there. And it was really well designed for a meta-analysis approach. So here's a series of case studies that made up this meta-analysis. There was one group in Pittsburgh that had 389 children, but most of them were, in the 100 to 50 range. Unfortunately, the details of these publications did not allow for a meta-analysis to be performed, except for 3 papers, a group in Toronto, a group in Boston, and a group in Calgary. And you can see pretty convincing evidence, although the sample size was small, that the establishment of a multidisciplinary program to take care of these complicated kids was associated with substantial improvement in all-cause survival, as well as intestinal failure-specific survival. The point estimate of better outcomes of liver failure, enteral autonomy, and transplantation were also seen to favor, but didn't reach statistical significance to improve and accept the concept of multidisciplinary programs. And again, as someone who's been in the field for a while, we started the program in 1999 as kind of a boutique program with 30 children, and now in 2015, the U.S. News and World Report used the establishment or the presence of a multidisciplinary program as one of the checkpoints to achieve national stature, you believe, their approach. So it's really been a very interesting series of events. Another kind of very nice summary of the literature, which I like to cite, and it's not just because it was published in the AJCN, but it was a really nice graphical demonstration of what's happened over time and what the prognostic factors are. And these folks did not just a meta-analysis, which is the summary point that I showed previously, but a meta-regression. So they actually got the actual data and created and demonstrated regression curves on these outcomes. And it was a large number of children with intestinal failure, nearly 10,000. Really, they went through the literature, not just the English language literature, but other groups as well. And it was really tremendous. They had a mean follow-up of 4 years or so, with the prevalence of intestinal failure-associated liver disease of about 17%, with transplant less than 10%, enteral autonomy about 54%, as well as catheter-related bloodstream infections. Now, I will say that a rate of 3.3 per 1,000 catheter days is still a pretty high rate, and we can talk about that perhaps in the discussion. But the most important figure in this was the improvement in mortality rate. So the size of the circle is this correlates with the size of the study, and you can see a steady improvement in mortality rate as time has gone on. So that was really exciting to see. And it wouldn't surprise people to say that the residual bowel length was perhaps the most important factor that drove the rate of achieving enteral autonomy, namely being weaned from parenteral nutrition. It's not a perfect relationship, but it is a moderately strong one. And then finally, the mortality rate was directly correlated with the catheter rate bloodstream infections, as you can see here. And suffice to say, if anyone is having a catheter-related bloodstream infection rate of 10 or 15, or dare I say 25 per 1,000 catheter days, then they really need to think of how this can be improved, because it's clear that the literature would suggest that these are more than 2 standard deviations higher than one would want to see. Another kind of updated, if you will, multi-center cohort study was published by Gattini and colleagues from the University of Toronto. And it was very much done in parallel structure, including the paper, the journal that it was published in, which is Paul's Journal of Pediatrics, as well as the way in which the data were presented, in a very similar sample size of nearly 400. And what they nicely showed was that overall, the cumulative incidence of achieving enteral autonomy was quite rapid in the first year after enrollment in the study. But over the course of follow-up at 3 years, 4 years, 5 years, there still was a steady but incremental increase in weaning from parenteral nutrition. And meanwhile, the number of children who were referred for intestinal transplantation or multivisceral transplantation hovered around 10% or so, and the mortality rate was about that high as well. And the reason I say that it was important to do that in a parallel way of 10 years ago is that you can see actually very quite comparably the data from the PIFCON database is here on the left. So in 2012, we published data that suggested, again, the rate of enteral autonomy kind of was rapid in the first year of life, but then approached about 45%. But then compare the two transplant and death curves, which are here in 2012, which were each around 25%. So that was, a very high mortality rate still, and compare how they are in the modern day times when both transplantation and death are less than 10%. So what that means, of course, is that if the enteral autonomy rate of 45 or so percent is stable, but the mortality rate is declined substantially, as did the transplant rate, we're able to maintain these children alive on long-term parenteral nutrition much better nowadays than we used to be able to. And that's obviously the success points. And then finally, in 2001, we created this logistic regression curve to give us an idea of, well, what do we tell a parent when we're seeing them in the NICU or after their intestinal surgery? At what point do we say, listen, the chances of your child coming off parenteral nutrition is high or low, or coin flip? And the coin flip point is the point at which this sigmoidal logistic regression curve kind of cuts through 50%, probably weaning from parenteral nutrition based on data that we collected in the 1980s and 90s was about 30 to 40 centimeters of residual small bowel. And for decades, that was the number that I would approach and talk to families and say, well, if you have more than that, it's higher likelihood. If you have less than that, it's lower likelihood. But indeed, in a very few short years, 13 years between publications, a similar publication occurred from our institution, which showed that this logistic curve, which isn't as nice of an S shape just because of fewer numbers on the left side, really had shifted quite a bit to the left. So on the y-axis, number of patients, I should have described this a little bit better. On the x-axis is residual small bowel length, and on the other y-axis, the probability of weaning. All of the light gray bars are children who wean from parenteral nutrition. The dark gray bars are children who did not wean from parenteral nutrition. And now the flip a coin point of residual small bowel length is about 15 centimeters. So that's really a big difference in terms of prognostic information that parents are learning about. We are too. So let's talk about something a little bit more broadly than intestinal failure, which is this recurrent problems with infant formula shortage, which I imagine are affecting people here in California just as well. And before we do that, it's important to realize, well, how strong is the rationale for the use of elemental formulas in our children with short bowel syndrome? And it's kind of weak, to be perfectly honest. Julie Bynes, who was a former fellow in our program and now is a leader in Australia, really, when EleCare and Neocate were just on the market many years ago, she did an open label trial of an amino acid based formula in only 4 children, but all of them had been on parenteral nutrition for at least 2 to 4 years. And all 4 of them promptly weaned from parenteral nutrition. And those who were measured had better measures of intestinal permeability and increased disaccharidase concentrations, leading credence to the idea that maybe this intact protein formulas were causing more intestinal damage than were tolerated in a child with normal intestinal length. So that was kind of the first important publication that led to widespread use of amino acid-based formulas. And then our study a few years later was a somewhat larger study, but still a small sample size of about 30 children with intestinal failure. And in a univariate way, so we didn't correct for other confounding factors, we found that there was a negative correlation, a significant one and a substantial one, between the percentage of days the child was fed an elemental amino acid-based formula and their duration of parenteral nutrition use. And in fact, the same significant correlation was found in the percentage of days fed human milk as well. So this paper, uncontrolled and not prospective, was highly influential, along with the Bynes paper, of using amino acid-based formulas for children with short bowel syndrome. I mean, there are physiologic reasons for this as well, because with reduced surface area, amino acid-based formulas lead the bowel to need to do quote unquote less work, and amino acids can be more readily absorbed when the surface area is less, as well as medium chain triglycerides and lactose free. But then just about a year ago, I was on call for the short bowel program, and I got this panic page from a mother of a child with intestinal failure. It was right before President's Day weekend, and maybe it happened out here too. She said, I'm in a group chat of 60 parents, and we just heard that the FDA has issued a massive recall on all of our formulas. All of our kids are on some form of amino acid-based formulas. So this had an impact here too, I imagine, right? I'm not just, what's that? Right, right. Well, I was a little bit late, I guess. It was Friday night. And of course, the Sturgis, I'd never even heard of Sturgis, Michigan, but I had heard of Coronabacter Sakazaki in terms of the potential contamination for powdered formulas. And this was another issue, of course. And it was terrible. I mean, our patients were really stuck. And our dietitian, Reese, actually, at the Pediatric Intestinal Failure meeting in Toronto, produced a very nice case series of 13 children who were all on at least 60% of their enteral intake as an amino acid-based formula. They all had a delay in receiving an alternative formula, with 3 out of 4 receiving no or diluted formula for at least 7 days. I mean, these kids were supplemented with Pedialyte for a long time. The mean weight loss during that time, these are kids who should be gaining weight, of course, they lost about 800 grams. 3 required more IV support, and 1 patient had electrolyte derangements and needed to be hospitalized. So the impact of this was obviously quite profound on our smallish number of children. But indeed, the whole idea of how could this happen in the United States really was terrible. And one of the advantages, which Paul now has too, is kind of having a bully pulpit on a journal. And so Steve Abrams and I wrote this editorial a few months later after the formula shortage. And we said, really, this is not only terrible for the short gut community and the metabolic community, but it really has to be investigated. So there really needs to be a much more transparent investigation in how this was allowed to happen, because indeed there are reports that people in Congress and the FDA had received reports several months earlier that things weren't going so well in this factory and failed to investigate that. The idea that we are relying on a single manufacturer or a single manufacturing plant for specialized formula is just crazy. It's almost like saying, oh, Moderna, why don't you just make the COVID vaccine in one site and the other companies don't have to worry about it? So that's not a good idea. I'm a big believer that the infant formula companies make marketing claims that are really skating on the border of ethical dilemmas. They name their formulas very close. There's a lot of mix-ups in terms of labels. There are claims that are made that probably aren't completely supported by the evidence. The lack of randomized trials to support formula choices, not just in short gut patients, but in a variety of other problems, is striking to me. WIC contracting practices need to be reviewed too, because again, the company that called the recall was a company that had the WIC contract in many states. And finally, the idea that our country is not really one that's in the vanguard of supporting breastfeeding families needs to be addressed as well. The topic obviously gathered a lot of international attention as well. And this is a really nice editorial from scientists in South Africa. And they point out the following. The crisis has exposed the risk inherent in an infant feeding culture reliant on commercial formula produced and marketed by a few consolidated transnational corporations with considerable political backing. The USA is only one of 14 high-income countries without legal measures to enact the Code of Marketing Breast Milk Substitutes. An urgent attention to address the upstream determinants of low breastfeeding rates should include efforts to improve maternity protection, legislate breastfeeding-friendly workplaces, and enact tighter regulations on formula marketing. The continued commercialization of infant nutrition is not a sustainable long-term option. So it's really an important concept for us as pediatricians to think about outside the narrow confines of short bowel syndrome. It's attracted the popular press, of course, as well. And indeed, this idea that it adversely affected people who are on WIC and other marginalized communities is the topic of a very interesting sociology paper from folks at Johns Hopkins. So really a lot to think about in this concept. So in the next last few minutes, I do want to talk about recent developments in the treatment of pediatric intestinal failure, having hopefully set the stage in terms of its epidemiology. And I will say that we'll now look back on the years of 1990 to perhaps 2012 as, I don't want to call them the dark ages, but the limited therapies that are targeted to the underlying pathophysiology of short bowel syndrome made us reliant on non-specific nutritional, surgical, and medical therapies for the care of these children. We often encourage as much enteral nutrition as possible to reduce the dependence on parenteral nutrition, and there's good animal and other physiologic data to suggest that that's important. The idea of amino acid-based formulas I've discussed as well, but there is a school of thought that suggests that maybe polymeric formulas might lead to better intestinal adaptation processes. There's animal data to support that. James could talk about his view on lengthening and tapering procedures that have been intermittently used to improve mucosal surface area. And finally, our medical hands have been largely left with non-specific therapies of bacterial overgrowth, antacid medications, and use of anti-motility agents. There are some experimental uses of octreotide, racecattadril, crofelemer, but of course, none of these have been really rigorously tested in children at all, and certainly not in children with intestinal failure. And they're studied, these are hard trials to do with such a low sample size. The late Dan Teitelbaum and his group a few years ago did produce a very influential case series about 9 children with surgical short bowel syndrome who had presented with a variety of underlying conditions, including Hirschsprung's disease, but also necrotizing enterocolitis. And interestingly, their symptoms were all notable for presenting with chronic partial bowel obstruction. So they often underwent surgical therapies to redo anastomoses. But the interesting thing about these children is that histologically, they look like Crohn's disease. So I'm not a histopathologist, but I can tell you that at the anastomotic site, you can see epithelioid granulomas on either side here. In the colon, there's a crypt abscess, which is a characteristic feature of inflammatory bowel disease, and a lot of lamina propria inflammation. Biopsy C, you can see again these classic kind of epithelioid granulomas. The gross specimen of this patient's small bowel resections showed a number of small ulcers, but also this whopping ulcer that is not commonly seen unless at the site of an anastomosis. And on perirectal exam, these children were also found to have kind of fistulizing diseases, and on endoscopic examination, aphthous ulcerations. So this really brought up the issue of whether these children would benefit from some of the newer biological therapies that have been used in inflammatory bowel disease. And I can tell you that we've relied on them in the treatment of a handful of children with stricturing disease or children who have severe intestinal inflammation. And I think the jury's still out about whether it's a home run or not. But it is something to consider in a child who's really kind of off the charts in terms of presenting symptoms. The use of antibiotics is actually a really somewhat controversial area, with obviously CDC and others wanting us to restrict the use of antibiotics, but we actually are pretty generous in our treatment patterns because we often do upper endoscopies and send fluid off for duodenal aspirates and cultures and use that for targeted approaches for antibiotic therapy. And my colleague Ali Carey was senior author in this paper recently published in JPGN. Of our cohort of over 500 children, about 100 had undergone upper gastrointestinal endoscopy, and clinical data before and after endoscopy were available for 56 of those patients. And what you can see is that symptomatically, 6 months after the endoscopy, after which they were often treated with antibiotics, their symptoms of feeding intolerance, abdominal pain, high stool output was substantially lower. And interestingly, even though their enteral nutrition tolerance wasn't statistically increased, their weight for age Z-score and BMI Z-score increased significantly, lending credence to the idea that chronic inflammation, kind of like a patient with inflammatory bowel disease, who often suffer from low height and low weight Z-scores, is also affecting our children with short bowel syndrome, and intermittent therapy with antibiotics can help obviate those signs and symptoms. So something to think about. But really the most important kind of development, and I probably mentioned this when I was here last, is the use of glucagon-like peptide 2 analogs. So the intestinal enteroendocrine cell produces a hormone called proglucagon that is cleaved by intestinal peptidases into subsequent molecules. And people know well, I'm sure, the story of GLP-1 analogs, and it's been recently used for children or adults with non-alcoholic fatty liver disease as well as obesity. But GLP-2 is a specifically intestinal trophic molecule, as shown quite nicely by Doug Burren and many years ago, where the intestinal features of a newborn pig who receives newborn milk is nicely shown here with nicely developed crypts and villi. If that pig is made NPO and supported by parenteral nutrition, there's a degree of mucosal atrophy that's quite marked. But if that same model is supported with TPN and GLP-2, you can see a very rapid improvement and increase, hypertrophy, if you will, of the mucosal surface area. And it is indeed that therapy, GLP-2, modified to increase its amino acid composition to increase its half-life, that has led us to develop a drug called teduglutide. And the really kind of influential study that was done in adults first showed that regardless of the dose of teduglutide, the reduction in adults of liters per week of parenteral nutrition was sustained and substantial. So this is what led in 2013 to the FDA to approve the drug for use in adults. And sadly, it wasn't until 2019 that a similarly designed study in children led to its approval by the FDA in children. This was a 24-week study in which children were randomized to receive 1 or 2 doses of teduglutide. It's given subcutaneously, and there was an opt-out to be part of a standard of care arm for 24 weeks as a comparative arm. And in these 2 graphs, you can see again the percentage reduction in parenteral support, calories per kilogram per day, was compared to the standard of care group, which was, there was no weaning of parenteral nutrition. Both arms on the teduglutide active treatment had a substantial, approximately 30 to 40% reduction in caloric support with active treatment. And one could argue, well, maybe they did that, they weaned the PN and the children became undernourished. Well, in fact, the weight for age Z-scores over the course of the therapy was the same in both control groups and the active treatment groups, lending credence to the idea that these children actually were absorbing more with this GLP-2 therapy. So that's all well and good, and the drug indeed was approved for use by the FDA, but 2 things are striking about this graph. Number one, well, what happens when you stop the drug? They only presented data for follow-up for about 4 weeks. And adult data would suggest that adults taken off of GLP-2 regress to their pre-treatment baseline in terms of stool output. And we've seen that anecdotally with kids as well. And so we've actually, once we started this drug, we almost never stop it, because once we stop the drug, these children have chronic diarrhea and poor absorption as well. This is a child who actually weaned totally from parenteral nutrition. She was on PN for about the first 5 years of her life. She was one of the first children in the country to have exposure to teduglutide, because she was part of our first randomized trial there, and she's still doing well several years later. Central line is out. She's able to go swimming and is leading an active life. Lisa Jimenez is my colleague, and she and I and others are participating in a long-term safety and efficacy study of exposure to pediatric teduglutide. This is a registry study. We designed it by asking people who had participated in among the earliest teduglutide trials to participate and follow up those children who had started on the drug several years ago. So we've completed enrollment. We have about 120 children who've been on teduglutide for several months to years, and we're anxiously looking into the data to see whether it's a long-term safe and efficacious drug to use. The data in adults about teduglutide use are also helpful, I think, to consider. This is a study, again, a short-term study, but in a large number of children, a large number of adults. And what you can see is that the highest volume of parenteral support at baseline, which is on the far right, was correlated with the largest decrement with medical therapy. But interestingly, there was no significant relationship between residual small bowel length and the response to therapy. So it is one of these cases where it's the physiology of these patients that's important to consider, not just the anatomy. In adults, there have been a number of adverse reactions that have led us to be concerned about that possibility in children. This is a growth-promoting agent, so the idea that these children could develop either small or large intestine polyps really has to be taken seriously. In adults, this has been well described. Gastrointestinal obstruction can occur as well, because if you have a kind of a tight anastomosis and you have mucosal proliferation, you can imagine where these children will develop obstruction. Hepatobiliary events, pancreatitis, and fluid overload have also been described. What we do is we measure fecal occult blood prior to starting teduglutide, and if that's positive, then we perform a screening colonoscopy We often never just do a sigmoidoscopy. And Ali Carey has actually done some very interesting work where she's done a total enteroscopy, because oftentimes kids are so short, you can reach the colon from an upper scope in the mouth and then do a colonoscopy, make sure you've seen the whole surface area. While they're on the teduglutide, they get an annual guaiac test. And after 1 year of therapy, or every 5 years while on continuous therapy, or on unexplained guaiac positive tests, and we repeat upper and lower endoscopies. Newer therapies include glepaglutide, which is a subcutaneous injection that lasts for 1 week instead of a daily injection. So that seems to help so much. And there are some suggestions that both from histologic and physiologic standpoint, this works quite as well as teduglutide. So I included this slide just to sort of say, well, it's nice to look forward to talk about new therapies that are coming down the pike, but it's also helpful to look backward. And so this is the classic study of Doug Wilmore and Stan Dudrick, where they said, this is our first case of a child with jejunal atresia who was supported, as you can see in these photos, very nicely by the use of parenteral nutrition. This was the original report in 1968. And you might say, well, that's great, Chris, but what relevance does it have for us today? I would argue that we are still, even though we've got 21st century drugs, the GLP-2 analogs and other approaches, we're still stuck on 1970s technology to measure its efficacy, namely body weight, length, and head circumference. And we really need to be smarter about how we measure efficacy of these newer drugs, whether it's measuring body composition, whether it's measuring physiologic measures of gastrointestinal function, whether it's new biomarkers in small bowel surface area, et cetera. So the world is wide open. So what are my take-home messages? All patients with intestinal failure, I think, present with unique therapeutic challenges. And that's important to kind of recognize, because I think there's a feeling among gastroenterologists and surgeons that say, well, these kids are so unique, it's really hard to group them all and learn about them. But indeed, that was the concern that pediatric hematologists surpassed decades ago. And we really need to kind of think creatively about pooling our data so we can know more about the natural history of this condition, so that really better guidelines can be developed, because there's a lot of what I often refer to as not as evidence-based medicine in the condition. It's called eminence-based conditions. And I guess that's an example of what you're hearing today. It really can be a lifelong diagnosis. So even though you can wean someone from parenteral nutrition, you still have to consider hydration status, micronutrient status, intestinal dysbiosis. There's a very high rate of renal morbidities in these conditions with chronic kidney disease due to perhaps dehydration. The psychosocial impacts of this chronic condition are huge, and they can be concerns at various life stages. I didn't include these data, but you'll have to take my word for it that endoscopic evaluations have a very high diagnostic yield and can be very helpful in driving therapeutic decisions. And in addition to physicians, nurse practitioners, dietitians, social workers, speech and language pathologists, nurses, and other staff, we, and I'm sure you do too, rely on a number of different colleagues throughout the hospital environment to take care of what are complicated and challenging patients. And I would say that many new areas are developing and make it an exciting field to consider. The long-term cardiometabolic health of these patients has never been investigated. The transition to adult providers is a challenge I hear in Stanford as well as in Boston. The use of stem cells, new lipid formulations, et cetera. That's really a wide open field. I'm lucky enough to work with a large number of colleagues who are all focused on the care of children with short bowel syndrome. And in a shameless act of self-promotion, I will say, if there are any dietitians on the call or in the audience who would like to work with us in Boston, there is a very large, there is actually a $10,000 sign-on bonus for dietitians who would like to come work with us at Boston Children's Hospital. Okay, I will stop here and take any questions. Thank you. So,
Thank you, Chris. That was really enlightening. And hopefully the audience took something from this, even if you're a general pediatrician, a subspecialist, not in GI. And the formula recalls affected all of us. And so there are many questions on the Q&A, and I can pull them up. Would anyone like to start, though, with asking a question?
I have a GI question. The kids that are
teduglutide, yes, it's one of those nuclear.
So what is there? But what does their enteral profile look like for feeding over time? Does that improve as well?
Yes, yeah. The idea is that they would advance on their enteral nutrition and reduce their parenteral nutrition.
What types of formulas?
Oh, we still rely on often amino acid-based formulas with this idea that absorption is limited. So using a pre-digested approach still improves absorption. You bring up an important point, though, because if someone is really stuck on parenteral nutrition and is only getting 5 or 10% of their total calories from enteral route, in our experience, we haven't used teduglutide at that low level of enteral tolerance. We've basically said, well, maybe the 10% of calories can get up to 30 or 40%, but is that really worth the subcutaneous injection of every day of your child's life? And furthermore, I didn't mention this, but the cost of this drug is only $400,000 per year. Yeah. James.
Thanks, Chris. This is great review, excellent talk. So it's remarkable to see the improvement in mortality in that duration just within your career there at Boston Children. That has changed. And oftentimes when people talk about this, they say it's because of a intestinal rehab team.
Right.
Can you tease that out and say what specifically?
That's really a great question, James. And of course, it's hard to do scientifically because we didn't randomize children to get multidisciplinary care or not. But my strong feeling is that by putting together a group of people whose thoughts and efforts were all uniquely kind of focused in on a complex problem, that was critical to developing approaches that were helpful. And by that, I mean the aggressive teaching of people how to maintain central lines in a sterile fashion to reduce line infections, the use of ethanol locks to prevent those line infections, not using antibiotics. The development, as you well know, of Omegavan, which Mark Puder and Kathy Gura put together, the development of GLP-2, which started in the University of Toronto with Daniel Drucker, and the widespread acknowledgement that errors would be much less likely to happen when all of the providers would be in the same room taking care of the patients and together. So it's hard to tease them out, but I do believe that those are all the major points. What do you think? Let me ask you that.
We're seeing these kinds of things in other areas, like cancer care. Wilms tumor used to be a very lethal disease, and with collaboration of all the different people, that has changed that outlook dramatically. So,
great. Thank you, James. And we're going to go to the Zoom for a minute, and when we come back, please introduce yourself. That was James Dunn from Pediatric Surgery, and Paul Fisher from Neurology previously. A question from Edward Leibovitz is, how do you characterize residual bowel length? Do you use centimeters or percentage? And how do you measure or estimate this?
The method I will ask James to comment on, but we rely on our surgeons when they're doing an exploration to measure bowel length on the antimesenteric border of the small intestine from the ligament of Treitz in bowel that's not specifically stretched out. James, is that accurate?
Inaccurate.
Yeah, it's certainly an art of medicine, not the science, but that is the big mechanism. We do rely on residual small bowel length in centimeters, but there are some interesting normative data that Paul Wales published that is very helpful to point out to the fact that a 30 centimeter residual bowel length in a 25-weeker is very different than in a full-term infant. So percentage of expected bowel length is often another metric that is helpful.
Great, thank you. We'll take one more Zoom question and then come back to the in-person. Elka Goyal from GI comments that we've had children here at Stanford with Crohn's-like phenotypes and short bowel syndrome. So she just wants to corroborate that with the slide that you showed. And she also asks us a question, which is, what is the recommended treatment in the antibiotic refractory patient? I think the question has to do with antibiotic use.
So we make empiric efforts to treat dysbiosis or bacterial overgrowth, our first drug of choice is metronidazole. Our second drug of choice is ciprofloxacin. If we are still running into symptomatic problems, then we often will refer for an upper endoscopy, duodenal aspirates, and titrate our antibiotics based on those results.
Thank you. And now let's go in the back, and then we'll take 2 questions.
Oh, hello.
Right here in
That
the
was so wonderful. Thank you so much, Chris. I'm
you.
going to steal so many of those pearls, and please do not steal any of our dietitians. We cannot afford to lose them. I think.
What's your name?
My name is Yo-Yo. I'm one of the physicians that take care of the intestinal rehab and intestinal transplant patients here. I think you have the distinct pleasure, as you said, and an honor of sort of seeing this trajectory over the past 24 years. And I wanted to know, and I think you sort of alluded to this, the next 24 years of this field and of this patient population, what are you most excited about?
Well, I think that the underlying conditions are often thought of as idiopathic in nature. And so no one really knows what the etiology is of NEC. I mean, people know what the pathophysiology is, but how can it be prevented? We need to do a better job at that. The etiologies of malrotation of volvulus, I mean, why does that happen in some people? We know there are a number of genetic causes of Hirschsprung's disease, intestinal ganglionosis, but my hope is that our colleagues in genetics will help us figure out some of the etiologies of the condition with the idea that some can be prevented. I think that the way we provide parenteral nutrition is still somewhat dated. We used to call it total parenteral nutrition, but that's clearly a misnomer because there's nutrients that should be in there that aren't, and nutrients that maybe shouldn't be in there that are. So I do believe we can get better at really meeting the nutritional requirements of these children. And obviously, I think the other kind of non-GI manifestations of this disease need to be appreciated and mapped out and treated more aggressively.
Okay, we've got maybe 2 more questions, and then we'll go back to Zoom.
Hi, Shweta Namzoshi, Intestinal Rehab. Thanks, Chris, for joining our division, and we really enjoyed your talk and your time here.
Thank you.
I have 2 questions, and you don't have to answer both. You pick whichever one you enjoy answering. One, I think, our families face a lot of inequity, and I wonder if you feel like there's a specific policy priority that intestinal rehab physicians could help tackle with other colleagues. And then 2, I think James and I talk a lot about bowel dilation, and what's your clinical gestalt on how to prevent that?
Oh, those are 2 impossible questions to answer. How about none? How's none work for you? Bowel dilatation, how you can prevent that? I mean, we think that that's part of the adaptive response, but it can be hyperactive, if you will. And it's not clear you can turn it on or off. James and I were talking the other day, there's some kids who don't develop any, and then some kids that develop in other places like the colon you might not expect. So that's a big black box. And maybe that's another thing that you and Yo-Yo can figure out for us. The equity concerns are real. I mean, this is a condition that increasingly affects children who have NEC, which, as you know, is disproportionately affects poorer communities in our country, and probably affects in other countries as well. And there's a lack of appreciation, really, of the burden of disease that falls on a large number of people who have difficulty accessing medical care in the first place. So it's a real underappreciated issue. It was really apparent in the early days of the Omega Van experiment to me, and I was talking to folks about this yesterday, in that the people who availed themselves of this new cutting edge therapy, which was quite helpful in reducing the morbidity of intestinal failure associated liver disease, were not parents of children who were in the community in Boston. They were people who were of means and could fly into Boston, relocate their family, and avail themselves of this therapy. So it was really a striking lesson and a sad one in many ways.
We'll take 1 more in person, and then we'll try to end with 2 Zoom questions in rapid fire.
All right. Michael Rosen and GI. Thank you, Chris.
Thanks, Mike.
So you showed the stark correlation between CLABSIs and mortality,
right.
I believe. And that, as you know, a GI doctor who sees these inpatients, that's we're often seeing CLABSIs and how much that impacts not just mortality, but just families. it's so inconvenient for families to have to come in for the CLABSIs themselves or just to rule them
Ruled
out.
about, yeah, exactly.
So what percentage of the variances CLABSIs do we know or do you think is related to line care? And what is what opportunities are there to better understand and prevent them?
Yeah, I think almost all are related to line care. I mean, there is this theory that the gut is leaky and translocation occurs, and I have seen kids with gram-negative sepsis whose line care has been outstanding. So I do believe that that does occur, but I do think that's the minority, and that would be supported by the microbiology of the results that we see. So I do think it's line care, which is hard in a young baby with high ostomy output and a skin that's filled of gram-negative and other microbes. But I think it's the main issue. I thought you were going to ask me another question, which is, well, what do you do in the setting of COVID or influenza season and the child presents with a fever and respiratory symptoms? We get asked that all the time, which is, well, how do you approach that? They've got a source of fever. Why are we admitting these kids? Well, we've had at least 5 kids with rhinovirus. I don't think we've had a COVID and CLABSI, but we've certainly had a number of kids with a concomitant respiratory viral infection, but also a central line infection. So we are still very conservative about admitting those kids and rolling them out.
Thank you.
Thanks. And if there's one thing I remember from Shweta's talks for the residents, it's lines up and tubes down. I got it right. And it's so important. And so the next couple of questions, and we may be able to go just for a couple more minutes, is from Dr. Florette Hazard, Kim Hazard. And the question is from a pathologist. How often have you seen polyps in these patients who I believe she's probably referring to the patients who received the GLP
Sure, yeah.
agonists. And what kind of polyps have you seen?
Allie and Lisette and I and Victor Fox were writing up a case series of people who had gastric foveolar polyps, who some of which had them before they were on Gattex, but they were discovered before Gattex was started, or in some cases after Gattex was started. And those can be seen obviously in children who are on proton pump inhibitor therapy. So obviously many of these children are on those drugs. So we've seen those. We haven't seen any colonic polyps, but stay tuned because there are some case series being published in AJCN soon about the presence of both colonic polyps as well as small bowel polyps. And at least 2 of the polyps were adenomatous polyps. So it's something we need to stay on top of.
Great, thank you. Dr. Dorsey Bass from GI has a question I'll just pose and you can decide how you want to answer it. Any notion of whether greatly enhanced prenatal care for underserved populations would be cost effective due to the reduction of short bowel syndrome?
Oh, well, it's probably, not only would it be cost effective for that indication alone, perhaps, but maybe Paul Fisher can comment on better neurodevelopmental outcomes, and perhaps others can comment on better outcomes from bronchopulmonary dysplasia and other chronic morbidities of prematurity. So for sure.
Great, thank you. And let's give a round of applause. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.